all and say that the power came. So we are okay, and hopefully it will be all right. So I'll start off today. I'm going to be doing tumors of the central nervous system. Okay. All right, so these are the learning outcomes. So you have to be able to explain clinical features of tumors of the central nervous system, and you have to be able to, you have to link it to a biological characteristic of the tumor type, right? So I will tell you how a patient will present. We'll discuss 4 cases, how they present. And then based on that, you can link it to, I'll tell you about the biology of the different tumors. And obviously, without biopsying of the tumor, you can't say it's this tumor and not another tumor, but you can have a rough idea as to what it might be, okay? Then you have to, second objective is to identify why different types of tumors are grouped together in the classification of CNS tumors, and to describe the macroscopy and the microscopy of some of the commonly occurring tumors of the CNS. Okay, so how I thought we'll do this is just by describing CNS tumors in the form of cases, and just for you to get an idea of the different mechanisms and ways in which central nervous system tumors present, because they can present in all kinds of ways. So here is case 1 is a 14-year-old boy. He presents with gradual blurring of vision of 5 months duration, and he also noticed a headache, and which is more prominent in the morning. Okay, then so that's one way. Now second way, second case 2 is a 56-year-old retired postman. He presented with focal seizures of the left upper limb, which lasted for 2 minutes. And he has been irritable for the past month and has been behaving in a socially inappropriate way. So that is a totally different type of presentation to the first one. Another way they can present is 69-year-old woman developed progressive weakness of her left arm and leg over the past few months. And she also felt an abnormal sensation in her head during the past few months. And another way that they can present is 56-year-old man with hearing loss, which worsened over a year. And he also developed sensory loss over the left side of his face. Developed a headache, which was different in nature from his previous headache. Everybody, by the time you're 56, you would have had many headaches throughout your life. But this was different, okay? All right, so now you know that they can present with blurring of vision, they can present with epilepsy, weakness of your limbs, or with headache and other hearing loss, etc. Okay, so if you take tumors of the central nervous system, let's talk about the clinical effects of these tumors, and let's go to the local effect of having a tumor in the brain and spinal cord. So your local effect is actually determined more by the size of the tumor and the location than by the nature of the tumor. Okay, so if you take nature, it might be astrocytoma grade 1 or astrocytoma grade 3 or a glioblastoma grade 4. That is not as well, not that it is not important, but in general, the size of the tumor and where it's located is as important, or maybe even more important, because the effects of it, the size and location have such a important, play an important role in determining what the effects are. So you can have focal epilepsy, you can have hemiparesis, hemianopia based on that. So that is about local effects. Now, if you take general effects, you can have a raised intracranial pressure because of just vasogenic edema, which you all are familiar with. Okay, but you can also have, it can also be due to there, you can have new vascularization with formation of new capillaries in the adjacent brain tissue. And what you have to remember in these new capillaries have not yet established a blood-brain barrier function. So therefore, they may permit certain substances to cross the blood-brain barrier. Things which normally don't cross the blood-brain barrier may not be prohibited or inhibited from crossing it. And the presence of these new capillaries means that these tumors can grow, and so therefore their size increases, and depending on the location, their general effects will also increase. The other thing about general effects is that symptoms are more insidious in primary tumors than in secondary brain tumors, because a primary tumor starts off at a location, and over time, slowly, little by little, it gets larger and larger and larger. Whereas a secondary tumor will come from somewhere and just deposit, and the effects of it may be a lot quicker than something which has taken some time to grow. Okay. Now, though I'm just telling you these general principles, remember, like all things in medicine, there are always exceptions. So when you have to know the general principles, but you also have to remember that there may be exceptions, and that general principles are not like just, true all the time. Okay. Okay, now what about biological properties of brain tumors? I'm doing this in a little bit of detail because brain tumors are slightly different from all the benign malignant tumors that you encounter elsewhere in the body. Because, and I'll explain it to you as we go. If you take biological malignancy has to be distinguished from histological malignancy, and it's important because the effects are slightly different in the brain. The brain is encased in the skull, and whatever tumor that you have, as it grows, it expands. And because the cranium is a limited, area within the brain, it can't expand more than to quite a size before you start getting all the symptoms, right? It's not like having say an ovarian mass. The ovarian mass can enlarge and come out of the pelvis into the abdomen. There's a lot of room for it to grow. It might grow very, very large, and the patient may have absolutely no symptoms. But in the brain, it's not like that. And especially at particular locations, they will be discovered very fast because the tumors in the brain are not able to expand, okay, without the patient noticing. So some primary intracranial tumors are histologically benign, but they can't be removed. Like, for example, if you have a tumor of the floor of the fourth ventricle, you can't get to it, okay? So it might be histologically benign, but it's just going to grow and grow and grow, and probably the patient will die of obstructive effects if it's in the floor of the fourth ventricle, etc. So there isn't much you can do about it, right? Even though it is a very benign tumor, and elsewhere in the cranium, it may not have killed you, but it might in this instance. And same way for, say, a tumor surrounding the carotid artery. Second aspect of this is some benign tumors like low-grade astrocytomas. They show what is called an infiltrative growth pattern because individual tumor cells extend beyond the margin. So why is that important? Even though it's a very low-grade tumor and the surgeon opens up and tries to remove it, some of these you may not be able to enucleate and remove the entire thing, entire tumor, which means it will recur. Okay, so because the cranium is it's a difficult place, and because the tumor might be infiltrative and not have a nice capsule which you can remove, it is difficult to maybe entirely enucleate it. Third aspect about it is you can get what is called intraneural seeding through the CSF, and therefore you have deposits in other areas of the brain, spinal cord, nerve roots, so that the patient can present with clinically with a carcinomatous meningitis. So you might, they might have features suggestive of meningitis, but it is actually more due to intratumoral seeding causing irritation of the meninges rather than the fact that there is actual tumor in the meninges. It may be something which is within the brain, but which has sort of come to the surface and breached it and got into the CSF. Okay. Other thing is, if you have a brain tumor, extraneural mets are uncommon. So from the brain, you're not going to get a metastatic deposit in the lung or something. Although the other way is extremely common. A lung malignancy might present as a brain tumor. That is actually very, very common. Okay. But brain malignancies won't present as lung tumors or renal tumors or like that. Okay, so extraneural mets are uncommon. Okay, so if you take the incidence and distribution of brain tumors, they comprise about 9.2% of all primary neoplasms. It's the second commonest cause of malignancy in children up to about 15 years, the commonest being the leukemias. They are unusual, well, unusual over the age of 70. I don't know, maybe we might have to modify that. This may have been true some years ago, but I mean, you can get brain tumors right at any age. And in children, 70% of primary intracranial tumors are infratentorial, which is important because the majority in children up to a particular age group, right? After about, I think, 8 to 10 years, all this changes, but in children, the majority of intracranial tumors, majority of them are below the tentorium. They are in the posterior cranial fossa. Okay, now there are a few interesting things about brain tumors which you need to know. Some tumors, right, have a predisposition for particular sites. Like if you say medulloblastoma, it's very likely to be in the cerebellum. If you say a pilocytic astrocytoma, cerebellum again, pilocytic astrocytoma, right? Now, I'm not talking of ordinary astrocytomas. Pilocytic is a very particular type of astrocytoma, again, cerebellum and hypothalamus. Then some tumors occur more commonly at certain age groups, like medulloblastomas. You get it in the first 2 decades, and especially in the first decade. And so later on, if you see something on biopsy which looks like a medulloblastoma, it's a lot less common, and you've got to think of other diagnoses, okay, other tumors which might look like medulloblastomas. So these are things which you have to sort of keep at the back of your mind when you are trying to assess a patient, okay. All right, so if you read books, you will find they classify tumors in all kinds of ways, right? You can get the glial tumors, you can get the neuronal origin tumors, then there are primitive and undifferentiated cells, then you have the meninges which cover the brain, so you can get tumors of that. You can get lymphomas, either primary and secondary, and you can get leukemias. And then, of course, you can get tumors of blood vessel. Those are the commoner type of tumors that you will encounter. And so now this is just going to be like a list, right? You have to know, say, if you take the glial tumors, which are the commonest primary tumors, the astrocytoma is actually the commonest tumor. And I'll tell you a little bit about these, right? I suppose when you first hear them, you will just sit and, memorize all this. But if you sort of, when you all are doing your appointments and if you kind of look around and get a bit used to seeing patients with these, hopefully you will sort of understand it a little better than just sitting and memorizing, okay? So glial tumors, astrocytoma is the commonest. You can get oligodendrogliomas, ependymomas, choroid plexus, and then glioblastoma multiforme is actually the sort of the grade 4 astrocytoma. That's a very malignant type of astrocytoma. And then the neuronal origin, you can get the neuroblastomas and the ganglioneuromas. And then undifferentiated are the medulloblastoma, which I told you, which you get mainly in childhood in the first 2 decades of life, in the cerebellum, very classically. Meningiomas, tumors of meninges are extremely common. I'll show you some pictures of those. And then these lymphomas and leukemias. And then the blood vessel origin tumors, right? Okay, so let's take this. This is a 14-year-old boy. Now remember, this age is important, okay? Because you're thinking, okay, what is it? Is it likely to be a glioblastoma? Is it likely to be astrocytoma? Could it be a medulloblastoma? Only thing, this is gradual blurring of vision of 5 months. So it's unlikely, isn't it, to be a posterior fossa tumor? Well, it might be if we'll have to look a little more at that. But at this age, okay, and blurring of vision, he has also had headache, which is more prominent in the morning, which is a feature of brain tumors. And you have this large whitish mass there in the brain substance, okay? So that looks like it's arising from the brain substance itself and not from the, cerebellum, or it's not something like medulloblastoma. This is actually arising from the cerebral hemispheres and in the region of, probably because he had blurring of vision, maybe something to do with the optic nerve or the optic chiasma somewhere there. Anyway, this is a large irregular whitish tumor, as you can see on one side. So this is an astrocytoma, which is the commonest type of glioma. Okay, it's a slow growing tumor, grayish white. It's got very poorly defined margins. Okay, that is important. If you are trying to resect it, can you see these margins? These are sort of infiltrating like that. So if you are trying to resect this, you might, you have to resect all this, otherwise this is going to grow again. Okay. And now usually this occurs in late middle age, so that 14 years is a bit unusual for it. Shows a marked tendency to become anaplastic, and you have these various types. So depending on the type, each of these types has particular clinical pathological features, which I won't go too much into. So just to tell you that they can be divided into 3 grades of progressively increasing anaplasia. So you have an astrocytoma of different types, you have an anaplastic astrocytoma, and you have what is called a glioblastoma multiforme, which is a very, very malignant type of astrocytoma. Okay, and it's macroscopically a lot more more well defined. Okay, so here's what an astrocytoma looks like. Here's a glioma in the brain stem, and this is an astrocytoma. What it looks like, it's made of these fibrillary astrocytes. Okay, you don't have to know too much about it, but you do need to know that it's a common tumor. It occurs in the brain parenchyma. It can occur at multiple ages, and it is actually the commonest glial tumor. Okay, right. Second case, 56-year-old retired postman presented with focal seizures of the left upper limb, which lasted for 2 minutes, and he had been irritable for the past month and had been behaving in a socially inappropriate way. Okay, now if you look at this, this is again an astrocytoma, but it's not, you don't just call it an astrocytoma. This is like a very malignant astrocytoma, so it's given a totally new name. It's called a glioblastoma multiforme. Okay, and you can see that on one side of the brain. Okay, so you can see that this is a very ill-defined mass. It's separate from the normal brain tissue. It's not very encapsulated. It doesn't have like a nice capsule. It seems to be sort of infiltrating everywhere, and you're getting bits and pieces of it all over on the other side as well. Okay, so this is the main mass on one side, and you're having pieces of it elsewhere. Okay, and if you look at a glioblastoma, it is very different from that picture of an astrocytoma, one of the main differences in it is these are areas of necrosis, right? Now the astrocytoma didn't have that. So this has necrosis. These cells are a lot more atypical. You have these large odd-looking nuclei. You have these, which are mitotic figures. That's a mitosis, that's a mitosis, this is a mitosis. So in one field, you're having a lot of mitosis, you're having a lot of atypia, and you're having large areas of necrosis, which are surrounded by these tumor cells, right? And if you look, you're going to have a lot of these vascular structures. These are vessels which have proliferated endothelium. That's another feature. So anyway, you don't need to remember. I mean, nobody's going to ask you any of that. They might ask you whether there's necrosis and a lot of atypia, and you would say yes. So that's what a glioblastoma multiforme looks like. And here's another picture where you're seeing right in the middle here, this whole area, this area is all necrosis. And then you have these tumor cells all sort of surrounding those areas of necrosis. And here also, if you look, you'll see mitotic figures. That's a mitosis, that's a mitosis, that's a mitosis. Okay, so you're having mitosis everywhere. Okay, right. Now, one other thing which I might just tell you, you can notice that he presented with what? Focal seizures. Why would he present with focal seizures? So where the tumor erodes and destroys the brain, you will have abnormal electrical activity. So that's not unusual. He's been irritable for the past month and has been behaving in a socially inappropriate way. So if you look, these are often when somebody starts behaving in an inappropriate way, do you all have any idea, anything, why might that be? Or rather, where might the tumor be?
Frontal lobe.
Yeah, see, frontal lobe tumors, normally, that's how they present, okay? So that might be a feature which you can look at, okay? Or which you can connect with, right? Okay, so just a few words. I don't know whether I think the other one comes later. Yeah. So I'll just tell you the other glial tumors. Here's an oligodendroglioma. It's not as common as an astrocytoma. But oligodendrogliomas, they are present they are common in middle life, and they are usually in the hemisphere, cerebral hemispheres with a gelatinous consistency. But what is important about it is one of the tumors that is calcified. Why is that important? You might see it on an X-ray. Okay, so that is the reason why that is important. It's calcified. And of course, these anaplastic and atypical changes are less common than with an astrocytoma. Okay. So that is an oligodendroglioma. And the other next type of glial tumors are the ependymomas, which occur, they are usually intraventricular, okay, and also in the spinal cord. And they are usually in the first 2 decades of life. The intraventricular in the first 2 decades. Spinal cord tumors occur in middle life. And prognosis is poor because of the site. You can't get to it, you can't remove it, you can't do even whatever you want to do, you can't get there, okay? So that is the reason that ependymomas are, especially the intraventricular ones, okay? Okay, this is important because this is a very malignant tumor, and but it can be treated, okay, if it's diagnosed. So medulloblastomas, they occur mostly in childhood, they occur in the cerebellum. I told you they are often infratentorial tumors, which occur in the first 2 decades of life, especially first decade. They tend to spread through the subarachnoid space, and they are composed of small, undifferentiated cells, right? So they have a very, very characteristic look. And patients often present with either hydrocephalus or cerebellar dysfunction. Their 10-year survival rate is not marvelous, but nowadays with surgery and craniospinal radiotherapy, and there are all kinds of newer things that are being done, right? But it's a highly malignant tumor. Okay, here's your medulloblastoma. It has destroyed most of the cerebellum. It's a very malignant. Can you see this solid white tumor? These areas, it's all breaking down. It's hemorrhagic and necrotic, right? So it's a in areas it's solid and white, and in areas it's showing you necrosis and hemorrhage, and it has destroyed a lot of that cerebellum. Okay, this is classic medalloblastoma. Okay, you get these dark small blue cells with very little cytoplasm, lots and lots of mitotic figures. Okay, they what you call a small, this is a small blue cell tumor, and they have this characteristic like what I call little rosettes. Okay, you don't need to know all that. They are just small blue cells, and it has an extremely characteristic look. Okay, so don't forget medalloblastomas. They are common, very common, and they have a very characteristic look, and they occur in the cerebellum usually, and in the first 2 decades of life. Okay, getting on to the third case. This is a 69-year-old woman who developed progressive weakness of her left arm and leg over the past few months. And she also felt an abnormal sensation in her head during the past 3 months. So it's progressive weakness past few months. All right, so the diagnosis here is a meningioma. Okay, so you can see the brain there, and you can see this large tumor, which is kind of, it's coming from outside and pressing down on the brain and obviously causing problems. So what actually is a meningioma? It's a tumor of the meninges, and it arises from specialized, what are called arachnoid cap cells. Okay, it accounts for 15 to 20% of primary intracranial tumors. It's quite common. Okay, now see those sites, those are very, very common, right? Meningiomas occur in very, very characteristic sites in the hemispheric convexity. So where the the brain, the hemispheres, where in that it has a convexity right over the brain, right over that you can get meningiomas. You can get it from the falx cerebri, then they are called parasagittal meningiomas. That's another very common site, right along the top of the brain in the midline. You can get it. You can get it in the olfactory groove. Very commonly, you can get it in the base of skull, in the sphenoidal ridge. That's another very common place. And then, of course, you can get it in the within the ventricles and in the spinal cord. And they come on at middle age and later life. Very important. I hope I have a diagram. Okay, here's the diagram, right? So here's the brain. Here's your cerebellum. Here's your meninges. And can you see from that meninges, you are on the undersurface, you're having this large solid tumor. And as it grows, can you see what has happened? As it grows, it indents the brain. So naturally, the fibers in that area, whatever the fibers are, there's going to be some impact on the patient clinically, right? So the easiest thing in the world is to remove this, because these are not difficult to remove, especially this kind of location. It's very, very easy to remove. It hasn't infiltrated the brain because these are benign tumors. And it's very easy to remove this. Okay, so what are they like? Microscopically, they are well demarcated. They are firm, solid tumors. They can indent the surface of the brain, but they rarely invade it. And often there's thickening of the overlying skull bones. And microscopically, they have a very characteristic appearance. They have what is called a whorled appearance, because those meningothelium, the cells, they form into what are called whorls. They go sort of round and round in whorls. And so it has a very characteristic appearance. And the other thing about it is, this is the other tumor which you get what are called psammoma bodies or calcifications in it. Okay, I suddenly remember that I was supposed to record this lecture. I haven't, but anyway, I'll just put it up. Here's another meningioma. Again, this is in the midline, and here's your meningioma there. Okay. So Okay. And here is the meningioma. Remember I told you that you get these meningotheliomatous, these whorls, like you get these little whorls of meningotheliomatous cells. Here's your meninges. Okay, and from that you get this tumor here. Okay, and you can get these blood vessels, but mainly you get these whorls rounded like nodules of meningotheliomatous cells. So that is benign. Here you are. These are the whorls. That's one whorl, another whorl, another whorl. That's what you call a whorl. Okay. There aren't any calcifications actually that I can see here, but this is the other one that is that gets calcified. Previously, I told you oligodendrogliomas also get calcified. So meningiomas, most can be completely removed, and very rarely meningiomas may become anaplastic. Metastasis is very, very rare, but can, okay, I think you better forget that last line. Actually, I think I should omit that from this lecture. Can you please just forget that? I shall delete that, okay? That may have been true in 0.00001%, but it's not something you should remember, okay? For the most part, brain tumors do not metastasize anywhere. All right. Right. Now, let's talk about lymphomas, okay? Lymphomas, as you know, are malignant. Lymphomas can be primary or secondary. When you hear that somebody has a primary lymphoma of the brain, the first thing you have to do is what? You have to rule out AIDS, okay? Or you have to rule out lymphoma secondary to an immunocompromised patient, right? Because they are the ones who get primary lymphomas, right? They'll definitely be immunocompromised. So that is the commonest cause, right? Otherwise, it's very unusual to get a primary lymphoma. They are not common. Secondary, yes, absolutely, right? So primary lymphomas, they vary. Some are well defined, others are not. They often replace brain tissue rather than act as expanding lesions. And there's little evidence of increased intracranial pressure. The incidence is higher in immunocompromised and AIDS patients. You'll often find that if it's a primary malignant lymphoma, not often, always, okay? And most of these primary malignant lymphomas are high-grade B-cell lymphomas, okay? Okay, so have you all understood tumors, primary tumors? Let me see whether I have. Okay, right. All right, so those are a lot of those are the common primary brain tumors, okay? Now, metastatic tumors are a lot more common, very common. They account for about 1/3 of intracranial tumors. And there are some primary sites from which you can always get metastatic deposits. Small cell carcinoma of the bronchus is classic. Breast carcinoma, renal cell carcinoma, melanoma, and gastrointestinal tract malignancies, stomach, colon, rectum. Okay, so these are the common sites from which you can get metastatic deposits into the brain. Where do these metastases occur? Mostly in the posterior frontal parietal regions and the cerebellum, which is like, it sounds like most of the brain, okay? They are usually multiple, they are well demarcated, and they can have a little bit of edema around it, right? Around it, the adjacent brain tissue. And you can get deposits in the spinal extradural space. And obviously, if you get a deposit there, then you will have features of cord compression. And you can get meningeal carcinomatosis due to diffuse meningeal involvement. All right. So those are important about metastatic tumors. Unfortunately, I don't have any pictures and things. Okay, but basically, small cell carcinoma of the bronchus it looks, microscopically when you look. So these patients, they present with some feature, then they will be taken for surgery. They'll do a frozen section. They'll send a tiny piece of the tumor to the pathology lab. And what they will do is they will spread it on a slide and make what is called a crush smear. They'll sort of smear it on the side, the tumor tissue, and then they will stain it, and you look at it under the microscope. And then sometimes it's very easy, right? You can see the moment you look at it, this is a small cell carcinoma from the bronchus. It's very characteristic. Breast carcinomas, you will be able to recognize. Renal cell carcinoma is very commonly recognized. It has a papillary architecture and it has these large clear cells. Melanoma, they have huge nucleoli and they are very ugly looking cells. And colonic carcinoma has a particular look, right? So sometimes if you don't know, you can say. And the other thing is, please remember that these are not done in isolation. You might know that the patient is having, tenesmus and bleeding and has some ulcerated mass in the colon or rectum or somewhere, right? So there's a lot of clinical data which you have to know before you start interpreting all these tumors, okay? All right, so let's get to another part of it, which are the peripheral nerve sheath tumors. These may also occur within the cranial cavity and the spinal cord. Here's a schwannoma, also called a neurilemoma, which is derived from Schwann cells, okay? Now, these, let me see whether I have a picture of that. Yeah, here's a schwannoma. Okay, so here's your peripheral, the nerve sheath, and as you can see, there's a nice nodular mass. Very easily, it has been removed. It's a nice sort of circumscribed, looks very benign, looks very innocuous. And those are derived from Schwann cells. They are very well circumscribed, encapsulated. The vestibular, you can get it, if you get it within the cranium, it's often in the vestibular portion of the 8th cranial nerve, and then they are called acoustic neuroma. So when you say acoustic neuroma, what you mean is really you're talking about a schwannoma, also called a neurilemoma. Okay? And those are found, it fills the cerebellopontine angle. So that comes into the DD, differential diagnosis of tumors of the cerebellopontine angle, about which I'm sure you will be taught. There are 3 or 4 other tumors which occur in the cerebellopontine angle. If you don't know, go and read, okay? You can get deposits and various things there. So that is intracranial, right? But if you get schwannomas in the spinal cord, in intradural or in the dorsal nerve roots, it can occur in the dorsal nerve roots and therefore cause cord compression. So here's a 56-year-old man who comes with hearing loss, which worsened over a year. And he's also developed sensory loss of the left side of the face. And he has developed a headache, which is different in nature from previous headaches. And they found that he's got an acoustic neuroma, which is a schwannoma, which is a tumor occurring in the cerebellopontine angle. And that's what they excised. Okay. And that has a very, very characteristic appearance, right? So you have these spindle cells, but they are arranged like this. They sort of line up on one side, line up on the other, and in the middle you have this pinkish substance. So that's one type of area, right, that you might have. The second type of area that you might have is this very multicystic, loose-looking thing. So when you cut these schwannomas and you examine them, they have both these areas. Some schwannomas might only show this type of pattern, what is called Antony A pattern. And some schwannomas may have a lot of Antony B type pattern. But a lot of them, if you cut them and examine them, they will have both these patterns. And it's a very easy diagnosis. And it's sort of, if somebody says cerebellopontine angle tumor, it's most likely to be schwannoma, unless it's some malignant deposit from somewhere. Okay. Okay. Now, just a few words. So those are the common tumors, right? Now, I'll tell you a few things about cerebral edema and neoplasia. Cerebral edema, which occurs with neoplasms, is often what is called vasogenic in type, and blood-brain barrier disruption and the increase in vascular permeability are responsible for the disruption of for the vasogenic type of cerebral edema. Okay, so when you have a tumor, you have a like what is called a focal or mass effect results, and you can get increased intracranial pressure. And that raised intracranial pressure, as it increases, it can either reduce perfusion, it may reduce the perfusion, okay? So vascular perfusion, and therefore it makes the cerebral edema worse. Now, in the cranial vault, you know that there are these dural folds at various points which are very rigid, okay? And because of that, when this tumor is expanding, the displacement occurs in relation to these different dural partitions. And if expansion is sufficiently severe, you can get herniation, okay? This is cerebral edema, everything is sort of expanded and edematous. And when you have herniation, there are very particular sort of classic points through which the brain substance herniates. So underneath this phelps, you can get this area that's called a subphalcine herniation. That is underneath the phelps cerebri. You can get a subphalcine herniation, and you can also get uncinate herniation. So here is the uncus, this one, and that, as you can see on this side, you can see there is no uncus herniation on this side. This whole uncus has herniated due to increased intracranial pressure. Okay, on this side you can see that. And when you have this increased intracranial pressure and when there is herniation, you can get bleeding. And the end result of that is what I call this Durex hemorrhage in the cerebellum and maybe the midbrain pons area. Okay, Durex hemorrhage. And this is important because at postmortem, when these patients die and you want to find a cause of death and you don't know exactly why, when you do the postmortem and you cut, you look for these Durex hemorrhage because that tells you there would have been some increased intracranial pressure and herniation, and as a result of which you're getting hemorrhage. Okay, so that's really all I have to tell you all. Okay, did you all understand that?